what has to go into place to put together a diabetic retinopathy program, because I hope that that will be relevant to some of the work that VisionQuest does. And we did have experience with this. We helped the region of Kilimanjaro put in place a diabetic retinopathy screening program. And at that time, we had one retinal camera that had been made available. So and this goes for putting into place any kind of program, but with this particular one, we started off with this. It's important when you're planning programs not to say, oh, we're going to put a diabetic retinopathy program in place at this hospital. You've got to first say, what is the population you expect to serve? Jaro region. It was a defined area. You know what the size is. But that's where I think public health ophthalmology needs to start, is looking at the population that you hope to serve, not just the clinic where you're going to be giving the services from. Then you can start talking about, well, what's the magnitude of the problem? And that's what we had to look at in Kilimanjaro region. How much diabetes was there? If you know that, you can make some estimates about how much diabetic retinopathy you're likely to see. And most places don't have surveys that have been done to know how many diabetics there are, but there's some sort of estimates that will be available from the WHO, or lacking that, you can go into the various clinics that already exist, the general clinics, and do some assessments of their records and what they're actually seeing. And then, of course, there's lots of stakeholders involved, and you've got to get them all involved. If you sit down and just start planning your services and don't pay attention to other NGOs that might be out there trying to provide eye care services, or other NGOs that might be out there doing diabetic work, the doctors that you're going to have to deal with, the nurses, the clinical officers, that's a very important cadre in Africa, health assistants, administrators, all those people are stakeholders, and it's really important to have them involved in the planning of services like this from the beginning. If you don't involve them, somebody's going to be annoyed with you later, and it can really bring down a program. So it's good to get everybody involved from the beginning. And so when you sit down to plan, you have to first of all figure out, how's your system going to work? In this case, as I said, we had one retinal camera, and we knew we had to, before we even started thinking about providing service to deal with retinopathy, we had to set up diabetic clinics. We had to get patients all to come on a certain day. I think there were 6 or 8 district hospitals within the region. And so we had to help each of those district hospitals to actually set up a diabetic clinic and to start trying to get their diabetic patients to all come to a specific diabetic clinic, because you've got to have diabetic clinics if you think you're going to start dealing with diabetic retinopathy. You don't just go into general medical clinics and start looking for diabetic retinopathy. So we had to do that before we could even get started. And that's a big process. That took a year or so to get these diabetic clinics established. And then there's a lot of training that had to happen, training of the clinical staff, the doctors, the nurses, or clinical officers, but also training had to administrators. And a big cadre that we worked with a lot is counselors. Take the time to sit and talk to them to find out why aren't they coming in, and what needs to happen in order to get. He's made a big deal about training counselors who can actually spend time talking to the patients, and we found they're really important cadre in this going. Of course, then we had to have a lot of logistics to figure out how we're going to get the camera, because as I said, there were hospitals, we had one camera, so it had to go on a rotating basis to each of these clinics. And people have to be aware what day that they're going to have the clinic and get in there and be screened and then the camera broke and didn't function for a system in place for maintaining it and fixing it. So, all those kind of things had to happen. And then finally, it's important to have some kind of monitoring system in place. What do we do with all this data? We're collecting a lot of data, a lot of images, and sort of a regular review meetings. How can we improve this system? How can we make the clinics better? How can we make them function better? So a continuous monitoring process that needs to be planned for from the beginning.
What about after the detection and the treatment, either glaucoma or diabetic retinopathy? How do you make sure that the people that need the treatment get the treatment? And there's also a funding issue as well.
Well, as I said, I think most programs, most eye care programs in Africa are going to have to depend on some kind of external funding. Now, whether that comes from NGOs or whether it comes from ministries of health, patients cannot bear the costs, usually, of everything. Be reasonable to charge something for it, but there have to be systems in place to make sure that really can't pay anything, don't get lost. And there is no simple answer to it.
I wanted to switch gears a little bit and ask you about where artificial intelligence can play a role in this. So we hear about different diagnostic softwares being develop different integrated systems that integrate like a camera and a software together, and they look for or they screen for diabetic retinopathy or other eye diseases as well. So what kind of role they can play? Like they can probably solve issues of access, shortage of ophthalmologists, etc. And the relevant question would be, is African healthcare system ready to adopt such systems? I mean, maybe clinically, societally, or technologically?
Well, I mean, I think absolutely there's a role and great possibility for some of these devices, cameras and software that images is fantastic stuff. I mean, I think it's important to realize we get some of these tech solutions with the magic bullet. But what we really need is a magic gun. I mean, even if you have the magic bullet, you need a magic gun to get it out there. When you speak, Vinayak, you say these great cameras that can dive, for example. It's not the camera that does it. A person still has to be trained and be in the right place and get to the patient and get the image. And then you can get the diagnosis. And it's the management of those human resources and putting those systems in place that is really the bigger problem, I think. So I think, but on the other hand, I don't want to downplay the fact that if you have artificial intelligence systems that you can take an image and use it to do a diagnosis, that is going to be a tremendous help, especially where you don't have highly trained personnel who could do that diagnosis. So I think there's a huge potential, but I would hate to see, or I hate to see people misunderstand it's not alone enough to have the technology. Right, why it's important. Well, there's a lot of, about 200 million cases, as we say up there, per year in Africa alone. And Africa does have most of the world's malaria problem. There's a lot of costs associated with this. Almost 500,000 children, well, 500,000 lives lost to malaria, and most of those are children. Clinical pictures, that's a normal fundus, but here's some of the retinopathy, this white, fuzzy, fluffy findings in the background. And I didn't know what I was looking at. I thought it was really unusual. I'd never seen anything like it. And it was highly variable. Some of the kids had perfectly normal fundus, and some of them would have this whitening, and it could be present just a few little spots, or it could be covering massive area of the retina. And just when I thought, oh, I know what I'm looking at, I'd see another case that was normal, and I wouldn't trust myself. And there were also lots of hemorrhages, and I wasn't so interested in hemorrhages because we see those in a lot of other diseases. And there were these bizarre abnormal vessels that some of the children had that were really unlike anything I'd ever seen, and was able to so that he could do fluorescein angiograms. And that work allowed us finally to understand what we were seeing much, much better in the fundus of these kids. So the group in Liverpool has really taken this understanding a lot more of the detail of it. But the basics that these retinal signs actually are an important indicator of the severity of the infection is, still remains. And that we are able to see with just 50 patients. Now, one of the really important things, I think there's another, if you hit the animation, there's something else that comes up that came this, is the understanding that cerebral malaria was actually being misdiagnosed. Autopsy study, about 23 children who had been diagnosed with cerebral malaria during life and were thought to have died from that, on autopsy had another cause of death. And the eye findings were the best way to predict that. So that was also a dramatic finding, to realize that these eye findings were an accurate biomarker of malaria.
I wanted to ask you to maybe tell us a little bit more about what is happening that is causing these abnormalities, widening, the discoloration of the vessels.
Well, I mean, to put it simply, the whitening is hypoxia. I mean, retina that isn't getting perfused properly. And the abnormal vessels, when red blood cells are parasitized, the parasites consume the hemoglobin, and it's the hemoglobin in red cells and those red cells in retinal vessels that makes a retinal vessel look like a red line. So when the vessels are filled with dehemoglobinized red cells, they don't look red anymore. They look white or splotchy. So that's the simple explanation. You don't have a lot of ophthalmologists around to be doing these retinal exams. And in Terry Taylor's lab, she made a point of learning to do indirect ophthalmoscopy herself. And she made sure that a lot of the people working in her lab learned to do it. But that isn't going to happen very many places. I mean, Terry was really dedicated to this. So a camera that could detect it and could be used easily on a comatose child sick, you can't really prop them up at your standard retinal camera, even if to get pictures, and very unsuccessfully. So when Vinayak contacted me and said he wanted to not just develop this camera, but develop an algorithm that could analyze, and he asked me if I'd help. And I said yes, but I will be honest, I thought there isn't a chance in the world this guy's going to be successful at this. There's no way he's going to be able to develop an algorithm that can detect this retinopathy in the photos. And he proved me wrong. Congratulations, Vinayak. I mean, he did develop this algorithm, and we worked together for a couple of years. I looked at pictures, I think, that he had applied the algorithm to, and I graded them separately, and it was astonishing to me that his the detailed analysis that VisionQuest put into this, to look at these, mind-boggling to me. But now, this exists, this camera with that can take good images, good quality images, and actually analyze them.
Understanding the clinical barriers in a totally different market earlier in as in Africa, and then we realized that the challenges are more than just developing a piece of code or an algorithm. To look at the cost of the system that you're going to implement. You have to look at the size of the system and make sure it's to be accessed anywhere in the patient population. You also have to look at making it fully automated and user-friendly, so you don't have to be afraid of not having enough skilled people to operate it, or if people with ophthalmic knowledge to operate it. And just when we actually jumped into it.